I'm Margo Barnes, and I'm the psychology fellow for the LEAH training grant. And this is Dr. Janine Macklin, and she's assistant professor in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition, and also co-director of the Inflammatory Bowel Disease Clinic. And then this is Dr. Michael Barnett, and he is assistant professor in medicine and pediatrics and director of palliative medicine fellowship program. And I think also the assistant director of the combined medicine pediatrics residency programs. So, and especially as palliative care. So we're going to kind of talk about a case of a 15-year-old female diagnosed with ulcerative colitis in 2013. She also has, in addition to the GI symptoms, she has arthritis and joint pain and chronic tension headaches, and is followed by GI, rheumatology, and neurology on an outpatient basis here at Children's. It was initially sparked by an admission she had at the end of January. She's had about 7 admissions in the past 2 years related to her ulcerative colitis and 11 emergency department visits due to documented flares. So it's been a pretty comprehensive case. During the last admission, which Dr. Macklin will talk more about, she was followed by GI and then also consults with, I don't know if neurology consulted then, but rheumatology, palliative care, psychology, child life, and social work and nutrition. So it was a pretty big team that was managing our care. So I will let you talk about the GI specific stuff first.
Okay, so Kaylee initially was diagnosed with ulcerative colitis in March of 2013. She presented with abdominal pain, bleeding, and diarrhea. And so patients with inflammatory bowel disease can have these symptoms, and they can be quite debilitating. And when she initially presented, she had significant symptoms, and so she actually required admission to the hospital to control her disease. And she was started on IV steroids, which is kind of our mainstay therapy to initially get the disease under control. And then we try to advance patients to some other controller medications. But even with the IV steroids, just like when she initially presented, and even with the last admission that she had, she really didn't respond well. So she was changed to a biologic therapy, and basically those are either IV or subcutaneous type medications to control the disease and suppress the immune system. So initially she was started on medicine called Remicade or infliximab, it's a generic name, and she tolerated this well, but then developed an allergic reaction to the medication, and so it had to be stopped. And so eventually that September of 2013, she was started on Humira, which is another biologic medication to treat her disease. And she had actually done quite well on Humira. Now, during the course of her disease over the past 2 years, she has missed some appointments, and she's had insurance issues as well in trying to obtain her medications. And actually, when she came in with this most recent flare in January, she had been without her medications for the past couple of months. And so you can imagine, she presented in January with severe anemia that required a blood transfusion. She was put on high-dose IV steroids and seemed to respond at first, but then and was sent home, but then actually got readmitted a few days later with worsening stools, and we're talking about upwards of 20 stools a day that were recorded in the hospital, all bloody. And so she was quite sick when she came in, and so this is kind of where we were at. So she was made nothing to eat or drink by mouth. Is sometimes what we'll do to decrease any stimulation to the GI tract, and so it was decided she was going to be placed on total parenteral nutrition, which is an IV form of nutrition that you can give. But with that IV nutrition, you can only give it through a big central vein as opposed to giving it to a peripheral vein. So she got a peripherally inserted catheter in one of her big veins, and from that in her arm she got a clot in her arm. So at that point, we had to get hematology involved. You can imagine with her disease and how aggressive that it was. You know, it was quite depression. She was missing a lot of school. This is kind of, I think she's in 10th or 11th grade of school. So, and she's a very good student. And so the disease was really impacting her life. And so that's kind of where we were in both from the medical side of trying to control her disease, dealing with her acute issues, and also trying to deal with the psychological plus the sociological issues that we have with insurance concerns, mom missing work. So this is kind of a global issue that impacts families. But now, just to kind of divert a little bit, we're going to talk about what inflammatory bowel disease is. So basically there are three types of inflammatory bowel disease. There's Crohn's disease, there's ulcerative colitis, and then there's indeterminate colitis. And basically that's when we cannot decide whether it's a Crohn's disease or ulcerative colitis picture. Her disease primarily looks like it's ulcerative colitis. There's always a chance that you could be wrong with this disease because about 30% of patients that you think have ulcerative colitis actually have Crohn's. Now, it really doesn't matter for the treatments because they're really treated the same. What really matters is your long-term prognosis, because ulcerative colitis is curative by colectomy. So if you have your colon out, if you become so sick and you have your colon out, it actually rids you of your disease. Whereas Crohn's disease can affect anywhere in the GI tract. So there's always the risk that it may come back at any time, at any place, no matter if you've been taking all your medicines as you should or if you've not. You could be off medicines and do great. You could be on medicines and actually do terrible. So it's a very unpredictable, both the diseases are very unpredictable in terms of when you're going to have symptoms and when you're going to have flares. Right now there's no cure for either one, although I said there's a cure for ulcerative colitis. The only cure is colectomy, but you can imagine that's not without its own pitfalls. And you have to be diverted for a while, so meaning they have to have an ostomy where your colon or your intestinal contents are diverted into a bag, and so there's that. And then with Crohn's there is no cure, so it is a lifelong disease at this point. We don't know what causes the disease. It is a combination of something in your genetics plus environmental influences, because even in identical twins, it's not 100%. So one twin can have it and another twin cannot have it. So it's a very unpredictable disease. It's a very sporadic disease in who it occurs in. And it is a problem with the immune system. So your immune system is supposed to fight off the germs that we see. So any germs that we meet on the carpet or the table or anything, where our immune system is supposed to fight off those things. But with this disease, it actually starts to fight off the intestines, and it can fight anywhere in the intestinal tract. So we have to put patients on medications to suppress their immune system. And these medicines aren't, like Tylenol or simple medications. There are medicines that when you go to the pharmacy and you get the little printout of what they say what this medicine is, can be quite scary, because they're some of the same medicines that are used in cancer chemotherapeutics. So we use methotrexate, we use azathioprine. Now in higher doses, those are used to treat cancers. In low doses, they can treat autoimmune diseases, but still there's a significant risk there. And when you're telling teenagers and parents to say, trust me to put your child on this medicine that actually may predispose you to have bad infections or actually set you up for cancer, it's not an easy decision for parents or patients to make. But they have to take these treatments long term. And then even with treatments and even with medication, sometimes you still have to do surgery. So about 50% of patients with Crohn's will have to have surgery within 5 years of their disease. So it's not without even doing everything right, they still may have symptoms, or may require surgery. But again, with Crohn's, those surgeries are not curative. So this is kind of the discussions that we have, and it's a lot for an adult to take, but it's definitely a lot to take as a teenager when you don't know, you were fine one day and then another day you just weren't fine. So that's kind of what IBD is and its treatment. And then kind of going into some of the issues that patients face. Well, we talk about they have to take medicines. It's hard to take medicines. I don't know if anybody in here takes medicines, but to remember to take something once a day versus 3 times a day, the more times a day you have to take it, the less chances that you are actually going to take it and take it as directed. So just remembering to take medications. We have problems with patients hiding their medication, so they cheek them, and so they'll say, yeah, I took it, and then they spit it out. We can track some of these medications to let us know if you're taking it or not, but that can be a thing. or a problem. And then the other thing is, even with, we said she was started on Remicade, and, that's an infusion where you have to come into the hospital, not be admitted, but come into an infusion center to receive the medication every 4 to 8 weeks. So you can imagine how disruptive that can be for life, where you have to miss school every 4 to 8 weeks. Or, with Humira, it's a painful injection. So it can be given at home, but it does hurt. And so having to deal with those issues of not wanting to take the medication. Oh, the other thing is, this is particularly a silent disease. So people look at you on the outside and you look fine, but nobody in social conversations asks, well, how many poops did you have today? Was it blood in it? We don't have those conversations. So oftentimes they suffer in silence because their friends don't know that they spend all night in the bathroom, or they spend all day in the bathroom, or they get in trouble with teachers because they say, well, you just came to the bathroom and you got to go back again. It's true, because that's how irritable and inflamed the colon is. But again, nobody really understands the burden of disease, because you look fine. If I cut off your arm, then you could obviously tell this person has a disability, but sometimes we don't think how disabling this disease can be. Other thing is, if they have to have surgeries, most likely they're going to be diverted. So they're going to have an ostomy. And what happens with issues of, if I can't hide it beneath my clothes, I want to go swimming. We're all going to the lake. We're all going to the pool. We're going to the beach. I want to go out. Well, you can't have your bag. There's the shame that comes with having this artificial apparatus and pooping in a not natural way, because we're not used to seeing those things. So just kind of dealing with those kind of issues can be problems. And then just the normal adolescence. So we all went through it, and we know that you couldn't pay me to go back through it. But just imagine you have normal adolescence, your body is changing, and then you compound the issues that you're having with this disease. Because there can be issues at times where you can't gain weight. I mean, that's, I always say, well, I want Crohn's for a month so that I can lose some weight. But, but it's not when you're not trying, and people say you're too thin. And, or people say you look great, and you're like, I'm not trying to lose weight, and you're actually trying to eat, and you just can't hold on to your calories. It can be a problem. And the other thing we think about is height, so your growth is highly dependent on your intake. So if you're not absorbing your nutrients well, we can have boys who their final height is 5'2". Well, that's a problem, because, girls want a 6-foot guy, if possible. So growth is a big problem. And so if they're not absorbing their calories well, if they're not doing well, or their disease is not well controlled, then you compound the issues that they're already having with normal adolescents with kind of growth dysmorphic problems as well. So, and then you can have delayed, sexual maturation. So where girls are 16 and they've not had a period yet, no breast development. So all these things are things that we look at when we're saying, is the disease in good control? Because even I say, if you're not having symptoms, but if you're not growing, if you're not developing those secondary sexual characteristics, your disease still is not under good control. So it really is a very complex disease, and a lot for these patients to have to deal with at such a young age.
Mm-hmm. Absolutely. You want to discuss the chronic pain?
Yeah, so what I thought I'd do is just talk a little bit about chronic pain, something that is kind of a black box for most of us. Talk specifically about how that affects adolescents, and then explain a little bit how the world palliative care got involved in a patient like this, and sort of how is our approach to treating chronic pain. By definition, chronic pain is any pain that extends beyond 6 months, comparing that with acute pain. Now, if you look that up in textbooks, even that definition varies. Some people say 3 months, some say 6, some say a year. It just varies. Another way of thinking about it is it's pain that extends beyond the period of expected healing. So it's sort of pain that's beyond or out of proportion, that they should be better by now. And we all sort of get that sense from some patients that they should be better by now. Why are they still in pain? We then classify it by the type of pain that it is. And so this is sort of going back to basic science, that there's nociceptive pain. That's pain related to damage to certain tissues in the body, comparing that with neuropathic pain. So issues with the nerves themselves and the transmission of pain signals. We then subdivide nociceptive pain into somatic pain, which is muscles, bone. That's when you cut yourself, you can point directly at it and say, my knee hurts. Contrast that with visceral pain, all the viscera, all the organs inside, which is much more nebulous. It's much more abstract. It's often referred. So when people have gallbladder pain, that's referred to a shoulder or a scapula, or heart attack, that's referred down their arm. That's visceral pain. And why that's important for kids with IBD is because the pain complaints they often complain of are unusual. They're diffuse. They don't make sense. They may hurt up here, but their disease is elsewhere. And so that becomes a challenge because the story sometimes doesn't match maybe what we see on scans, or maybe we see nothing. And that's a real challenge in how we approach those patients. How does chronic pain develop? We have no idea. But we know that there's real changes that happen in the nervous system for kids and adults that are in pain for a long time. And something is happening when you have persistent nociceptive or neuropathic activation in the pain pathways, that there is a central sensitization, sometimes you hear it called amplification, that the actual modulation, how they perceive pain, begins to change. How does that manifest? Well, you see kids that have things like hyperalgesia. So they get a little bit of gas pain, which we all get, and it hurts for a second and then it goes away. Theirs becomes excruciating, severe, and it revs up and they can't stop it. So that's hyperalgesia. Or allodynia, which is where a non-painful stimulus causes pain. So basically the nervous system is out of whack. How those pathologic changes happen, we're not really sure. There probably is a genetic component. So how does one person have an IBD flare, they get over their flare, and they don't go on to have a chronic pain? Their acute pain stops, they leave the hospital, they're fine. But the next kid comes in, has an acute flare, and their pain never stops. There's something that probably predisposes some kids to developing chronic pain. And there's probably changes that are happening in the brain itself and how they perceive pain. And we'll kind of come back to that. Pain affects everything. So pain is never in isolation. And so we tend to see a lot of comorbidities, issues with sleep, issues with mood, issues with just generalized function and activity. So again, pain is a comprehensive problem. What does it look like in teens? Well, there's more literature coming out specifically looking at chronic pain in adolescents because it's becoming a bigger problem. There's some estimates showing that in the last 10 years that inpatient admissions for chronic pain in teenagers has increased by over 800%. They seek more medical care, they use more medicines, they miss more school, they have less quality of life, which makes sense, right? Intuitively, we all get that if someone's in chronic pain. I think one of the biggest things, and Margaret will probably talk about this, one of the biggest challenges, especially in teens, is that chronic pain leads to social isolation. So you add IBD, someone with body image issues, who is stuck in a bathroom all the time, who can't go to school, and now you add chronic pain. If you have chronic pain or have been around someone with chronic pain, you don't like to be around them, right? Because they hurt, they complain, they're depressed, and so they get more and more and more isolated. The exact opposite of what we want our teenagers to experience, because this is the time when they're finding themselves. Kids, adolescents with chronic pain, estimates vary, but probably somewhere between 40 and 80% of them will go on to be adults with chronic pain. This will be a lifelong experience for them. And there's a really interesting study that came out in the Journal of Pain just last September that looked at all teenagers coming to chronic pain clinics in the United States, and they looked at medical utilization of cost of caring for these teens. It's an estimated $19.5 billion is spent caring for teenagers with chronic pain in the United States. This is a huge problem, a huge problem. So what do we do? And how in the world did palliative care get involved? Palliative care, right, is a medical specialty devoted to treating suffering, to relieving the suffering of disease, chronic disease. We often think about it in terms of life-limiting disease or serious illness and death. But especially in pediatrics, we tend to be much more upstream in taking care of kids just dealing with serious illness. By definition, we are interdisciplinary. So we model our service off of the hospice model, which includes medical care, nursing care, social work, pastoral care. And the idea is that pain is what we call total pain. That pain is not just physical, but pain is emotional, pain is social, and pain is spiritual. And that to treat pain, we have to treat it holistically. If you try to treat one aspect of that, you will fail. You have to treat all the pieces of that. So our first step in approaching any teenager with chronic pain is telling them that we believe them. For most of these kids, they've been told over and over that the pain is not real, that we didn't see anything on your scans, that your CRP is fine, that this is in your head, or it's just blamed on that they have depression. They say, oh, well, you're just depressed. You're just depressed. And you can imagine how even more isolating, because now this kid, this teenager is thinking, not only do I feel this way, but now they're telling me I'm crazy and that I'm just drug seeking. So the first thing we have to do is tell them that we believe them. Their pain is real. Does that make sense? Their pain is very real. The second thing is that we've got to start thinking about pain beyond pain medicine. This isn't about drugs. This is about function. This is about living. This is about life. So our goal is not about numbers. We've done so well at training people to ask the pain scale. Now we can't get them to ask anything but the pain scale. But for kids in chronic pain, that pain scale can sometimes be worse for them than it is a help. We are more interested in, can they do the things that they want to do? What is their function? What is pain interfering with? Their pain may always be an 8 on the scale. But can they go to school? Can they learn to cope and deal with the pain that they have? Remember, a lot of these kids are going to go on to be adults with chronic pain. Somehow we have to teach them to cope with the pain that they have. And so at Children's, here in Alabama, we developed a chronic pain protocol and sat down together. And this really came out of our GI patients and IBD patients, realizing that we had a lot of the same kind of patients coming in struggling with the same issues, and said, how can we deal with these kids effectively? And so we created a protocol that involves all of the interdisciplinary team from the time that this kid hits the door, that we call Child Life, that we focus on structure and routine and distraction. So regardless of their age, we want to look at age-appropriate activities to get their life as normal as it can be in a very artificial environment of the hospital. We consult the school teacher, get them doing work. They may not be able to do everything that they can do, but they can do some, especially as they start to feel better. But getting them back into the daily routine. Having pastoral care come. For a lot of these kids, whether they're saying it out loud or not, they're having major existential issues with, why me? It's a normal question. And we need to normalize that for these teenagers, that it is okay to say, why me? And to deal with some of those issues from a spiritual or existential perspective. Physical therapy is huge. Remember, this is a lot about function and getting these kids moving. So as they begin to feel better, and as they have less things attached to them, we want to get them moving as quickly as possible to focus on coping with pain, compensating for pain. So how can you still do the things you want to do even if your belly hurts? And we see lots of kids that are able to go play basketball and their bellies are still hurting. And then obviously psychology, and this is going to sound like I'm plugging Margot and psychology, but I believe wholeheartedly that all these other pieces will fail if we are not addressing that piece. And she's obviously going to talk more about that. It is about retraining the brain, and that's what I encourage these teenagers and their parents, is that we didn't get here overnight. We're not going to get to a normal place overnight either. That it is a matter of slowly rethinking and believing that I can live my life in pain. The last thing we do as palliative care doctors is manage the medications, is look at the meds part. And I intentionally leave that at the last because I think the medications are a Band-Aid. They are a stopgap. They help us buy time while we're working on all these other pieces. We want to limit opioid medications. In general, opioids are not the right medications for chronic pain. They have a lot of side effects, and we want to teach these kids to cope, not to be dependent on that kind of medication for the rest of their life. Very briefly, long-acting medication is better than short-acting medication. We will work to try to get these kids on longer-acting opioids. We will try to get them onto PO medication as fast as possible. IV short-acting medication has the highest euphoria associated with it. And so we give these kids IV opioids. We teach their brain how good it is, and then we yell at them because they ask for it. But their brains are just doing what we have trained them to do. And so we want to try to get them off those medications as quickly as possible. Does that make sense? We also are going to use a lot of adjuvants. So we're going to do things to opioid spare. So a lot of old antidepressant medicines we use for neuropathic pain, TCAs, gabapentin, pregabalin, newer classes of medicines like the SNRIs, duloxetine or venlafaxine. So medicines that are getting two birds with one stone, right? We can treat associated mood issues and treat chronic pain. And in general, the antidepressants or anxiolytics are often hugely important. We have to address the mood. And sometimes that takes some time to get a teenager to admit that that's an issue. Sometimes we even have a harder time getting parents to admit that that's an issue. They are not crazy. This is normal. If you've lived in pain for this long, it is normal to be depressed. So we have to normalize it, believe them, and then start this interdisciplinary approach.
All right, so I'll talk a little bit more, since they both set me up for this, for the to the psychology side. So we were initially consulted on the case because of mood issues, as well as the discussion about the potential colectomy. And so we met with the patient, and she was tearful and she was upset, but pretty appropriate. And I think that was the first thing that struck me is, gosh, I would feel this way too if I were you. And we really did. Our first step at all that when we were working with her was to normalize it. Yeah, this stinks. You're in pain. You don't feel well. You can't do the things that you want to do, and that really is not pleasant for you. In terms of depression, we did not diagnose her with depression. We felt more that it was an adjustment issue for her. She did not show anhedonia. She was sad, but appropriately sad given her situation. She was in pain, so her somatic complaints were high, but we felt that it was more due to the medical condition as opposed to a comorbid depression. She was anxious, and again, that was also related to thinking about, well, what will happen to me if I have to have the surgery? What will I do? How will I go to school? She was highly motivated. I think her biggest issues were needing some more coping skills to deal with the chronic pain, and also just with the course of what her disease was going to take. And I think if you think back to when we were all adolescents, right? If you think back to that, imagining just your daily life in general as an adolescent, but then layer on a chronic illness that you can't predict tomorrow how you're going to feel. You don't know whether a flare's coming down the road. You don't know if your pain's going to feel better or worse. You really have no way to kind of mark your expectations, and layer that on top of being a teen and raging hormones. It's really tough. So I think putting it in that context and walking in and understanding that first is important. In terms of, in general, with IBD and mood issues, there are higher rates of diagnosis, but if you actually look at symptom clusters, they report less severe and lower levels of generic depressive symptoms than the general public and other chronic illnesses. Their somatic complaints are really high, but they tend to be related to their flares. So if their disease activity is high, then they're usually going to score higher on a screening of depression. But if you kind of go through that screening and pull the actual symptoms they're endorsing out, it's generally going to be more somatic in nature. So the better they get, the better physically and that their pain is doing, then the lower those scores get. So it's hard to mark it by the actual diagnoses, because sometimes I think they're misled by their relations to disease activity. Doesn't mean that the impact on functioning is any different, though, so you still address it, I feel like, the same way we would in any other context, right? Research has shown that cognitive behavioral therapy, and more specifically acceptance and commitment therapy, which is kind of a newer type of technique where you really get the patient to go, okay, this is how I feel. My pain is an 8 out of 10. I hurt. Okay, now what do I do? How do I do the things that I want to do? How do I get back to school? How do I engage in the activities that I want to engage in? How can I participate with my friends again? Particularly for IBD, I think that social isolation component is the hardest because it's embarrassing, right? I mean, I think any of us can admit that would be a really tough conversation to have with your friends, and I think because of that, they often hide it. It's one that they don't want to have to acknowledge to people or discuss with people, and will find excuses to get out of a classroom or to not go out to restaurants or participate in activities just for that fear of, well, what happens if I have to get to a restroom and I don't have one? And I think it's a sick cycle where the more they become withdrawn socially, then the more those mood issues increase. They become more anxious, they become more depressed, they then withdraw even more, and it kind of perpetuates itself. I imagine if I had been an adolescent and missed even a week of school, I would be have a really hard time going back. Well, what happened? What did everyone say? What were they doing? And then if you think about a prolonged course of that with ups and downs, it's a really hard time. In terms of kind of getting them back on their feet, we really work on cognitive restructuring, so addressing the thoughts that are there about their pain and how they're kind of what they're attributing it to and what they're thinking in terms of, okay, well, how can I get past that? Relaxation strategies, so deep breathing, especially when it's acute, and progressive muscle relaxation are generally helpful. There's sort of an irony, though, with IBD. When we come in to work with those patients, we actually don't really show much progress with the actual IBD symptoms. Their general pain gets better and their quality of life goes up, but they'll still say, yeah, but this, and this are still there. Like, okay, well, but again, it's a functional thing, right? So even if those are still present, if their functioning is better, they're re-engaging in school, they're re-engaging in the activities they want to engage in, then is that really how we want to quantify it? I think we want to look at function more so. Generally with patients with IBD, when you look at health-related quality of life, you can find improvements on almost all things. The hardest one to get the move with is the social. And I think, again, that's related to the symptoms. So when they're in a flare and it's just hard to be out there, you have to kind of go with the flare and wait till things get under control and then get them to re-engage. In terms of adherence, I think that's the other really, really hard part with adolescents with IBD. One, because of the medications that are used, any kind of body changes, right? Weight gain because of the steroids or any kind of physiological change that they feel that others will perceive is difficult. So they oftentimes will block it, not want to hide it. Not want to take it, so they'll hide their medicine or convince you that they did. The other that I think is particularly important for this one is that when they're in remission, when I'm not going through a flare, I feel fine. I don't need that medicine anymore. I feel great, right? No, hold on. That's what's keeping you in your remission. So kind of working with them to help them to understand that, yes, it's extremely important to control the current flare, but then why is it important for maintenance? Why do you need to continue to take that medicine regardless of the changes? And addressing that, I think, at every appointment is kind of routine care and helping them to understand, okay, yeah, you feel great today, but here's where we're still going to continue with this. Other things that can help with adherence. Oh.
How about in terms of compliance and adherence with diet, beyond just the medication? How is that? Because if you prescribe a diet to keep the gut resting, then they feel good. Is that need to be considered?
So that's a really good question. So the question is whether or not adherence to nutrition is kind of either quantified and or kind of paid attention to as much as to medication regimens.
And the only dietary changes that have been shown to be effective are liquid diets or semi-elemental diets, so meaning they have to drink their nutrition. Like 80% of their calories would have to be from a nutritional drink, and 20% they could eat foods. So most people aren't game to do that because we're social creatures. We like to eat. We eat our meals together, whereas you're eating and I'm going to drink my, Pediasure. Sometimes that can be a challenge. And some of the ones aren't very palatable, so they have to place NG tubes. There's some people who will place an NG tube at night to do night feeds, and they'll take it out in the morning, and they'll do that every night to control it. It does work, but those are the only diets that have been shown to be effective to this point. The only other diet kind of changes we say, if you have a lot of inflammation, would be low residue diets, which are kind of very low fiber foods. So anything that's hard to break down. So anything you have to chew a lot, you need to avoid that. So that'd be nuts, that would be popcorn, corn, raw vegetables, kind of salad. So it would be kind of opposite of what we think of as a healthy diet, just because those roughages will get caught up.
So just a follow-up, in terms of the age of the internet, if you look at internet, if you Google some of these things, some of the websites suggest with some bowel disease that high fiber, that studies show no difference between high fiber and low fiber. And then how, in terms of an adolescent who, of course, is trying to look for something on the internet, how do you gauge that, and how do you give that, we having that rapport established and not like you're dictating to the adolescent what they need to eat, how do you gauge that? Is that an issue at all?
Yeah, it definitely can be. So trying to, if they want to do a particular diet and we're saying, well, the evidence hasn't shown that. You definitely want to listen to them. You want to, if it's nothing that you would think would be detrimental to their disease, then I'm not gonna completely just, let's say, no, you got to stick to do it this way. Now, if there are issues where I'm thinking, your calories are horrible, you need more nutrition than you would get on a 1,000-calorie diet, because that's what you found on the internet as the latest treatment this person's blogged about. They did that, and now their disease is gone. That's not a study. And so I'll try to talk to them about, when we look at, research, and we don't know everything. So, there's no way for us to know everything. But I will talk to them about saying, if it seems okay, if they want to go gluten-free, well, you can go gluten-free. It's nothing wrong with being gluten-free if that's what you want to do. So, you just say, okay, so I just pick my battles. You have to dig your heels in where, if they want to say, I want to go gluten-free, if you want to go gluten-free, as long as you're going to take your medicines, okay. If that's what we got to do, I just feel like you cannot be, I don't think in any kind of relationship, as far, doctor-patient, you can be so, paternalistic these days. We have to be, because if you're not involved, you're not going to do what I say. So I've got to involve you in the process, and I want you to own this disease. I want you to embrace it. I want you to know and listen to your body. So if you say, I had a patient that every time he ate popcorn, he loved popcorn. So he would gauge how his disease was doing based on if he could go to the movie and eat a whole thing of popcorn. If he could, he said, my disease is great, Dr. Macklin. If he couldn't, he'd say, oh, I think I'm having problems now. But I need you to own it and to know your body, and to listen. But I try to still give them some autonomy that this is your body, you can control it. And if you want to do something, as long as it's not detrimental, then I let them do that.
And I think that's a really good point. I think with adolescents, it's getting their buy-in for any of the specialties that are working with them, right? It's getting them to say, yeah, okay, this is mine. I'm going to do this. And so helping them to set up their schedules for medications if they need to. Helping them to, set reminders or set their environment for whatever will make them succeed from whatever angle you're working on is of utmost importance, I think, specifically with that population. And then getting them, if they want that responsibility and they want to be able to manage it, having them take baby steps. Okay, if you can prove you can do this, great. Let's move to the next step, and kind of pulling the family away and letting them take more responsibility as they're able to demonstrate that. I feel like working with adolescents, especially probably with this population, is more of a fine art than it is.
Yeah. And you have to listen to where they are, because they may, say, well, I can't take my medicines because it interferes with band practice. Okay, if the band is important, we're going to have to work around the band. So I may have to hear a 10-minute conversation about the band and what you have to do to try to figure out then, well, how can we get you to take this medicine? Like, when would be a time in this band schedule that you can actually do that? Now, does that have anything to do with medicine? No. Does that have anything to do with Crohn's? No. But if the drum is important to you, then the drum is now important to me. Because if that's a part of your life, because that's a part of your well-being, our identity is not just, I'm a doctor or I'm a psychologist. You are more than just what your profession is. You have other things about you that make you who you are, and if we just negate those parts of you, then we're negating part of who you are. So we have to, like when I come to clinic, I make it a point to know something else about my patients, what they like. I had to hear about video games this morning because the 4-year-old wanted me to hear about video games. That's what I did. You do whatever they need because you're, again, trying to get buy-in. So if I am interested in you, you're going to at least listen and be at least somewhat open to what I have to say. If I just embrace, this is what you are, and I have to meet you where you are.
And I think that's actually a good bleed into kind of the take-home message from psychology side is most of these kids do great, right? I think we tend to highlight the difficulties they have. Most kids do go through periods of adjustment where they either are showing depressive symptoms or mood issues or struggling to engage socially, and it kind of takes a path of a roller coaster. But overall and across time, most kids do great. They re-engage, they meet the developmental milestones they need to, they become well-adjusted adults, despite ongoing pain issues sometimes. And so I think that's the umbrella you have to look at. Well, how can we make that the norm for everyone? So addressing the subset that do have difficulties, but also keeping in mind that most kids really do succeed and do well with it. I guess we can open it up for questions.
In terms of the pain associated with eating, how often do you find that they're scared to eat, and that's one of the reasons for their low caloric intake?
We find it fairly commonly, particularly when they're in a flare. And so when you eat, just kind of physiology, so when you eat a meal or anything, you'll have a desire to go to the bathroom. So that's called a gastrocolic reflex. And so you actually feel like you have to go. You don't go every time. But in these patients, it's exaggerated. So as soon as they eat, they've got to go to the bathroom. So they're teenagers. They know, like, well, if I don't eat, then I don't have to go to the bathroom. It makes sense. We would do the same thing. Just like if you had a stomach virus this morning when you left home and your stomach wasn't right, you wouldn't eat lunch. You would just say, okay, I got to get through this day, so I'm not going to eat. You do those things to try to modulate your day. So it's very common, but generally what I tell people, like, if you don't feel like eating like a meal, you could drink your nutrition. So like if you don't feel like eating, I say, well, you got to do a boost or you got to do an Ensure. You've got to still get the nutrition that you need, because again, it's not just take these medicines to control your disease. It's both medications, it's nutrition, it's the whole process, and just making sure that everybody's on board with that the family is cognizant that what are they eating, because sometimes you don't know what they've done at school, but if at home they're not eating well or they didn't eat any dinner, you've got to have everybody on board, because sometimes we'll see parents can be the weakest link. He just can't eat, or he can't go to school, or you have to kind of change the whole family's thinking about this chronic disease. Yes, they have this disease, but I still expect them to go. I expect them to live. Okay, I don't expect them to just stay in the house, not eat, not be part of life.
And they don't end up showing higher rates of specific food phobias or eating disorders compared to the typical adolescent population.
That was the
Yeah,
emergency.
I thought so. Yeah.
What about the use of appetite stimulants, especially in the kids where you're noticing stunted growth?
I will do, the only one I usually do is periactin or cyproheptadine in a patient that, who they just don't want to eat. If I think their disease is under fairly good control, everything seems fine, I will use cyproheptadine as an appetite stimulant. I don't use some of the other ones because they have more side effects, but periactin is fairly safe. It's a medicine that's kind of like Benadryl, so it makes them a little bit sleepy, but it will make them eat more the next day. So generally I'll do it at bedtime and then they'll eat more the next day. You can do it up to 3 times a day though. But I will try those, but when they don't want to eat, I say, to me it's an either or, and I don't give you, I can say, well, you don't have to eat, I'll let you have that, but if you don't eat, you got to drink. And then sometimes I'll say, well, if you don't want to drink, I can put a tube down and give it to you, and usually they say, no, I'll drink it. So I give them the option, but again, they're still a teenager, they're still kind of a child. You still have to exercise some kind of adult control, because a teenager's mind is not fully developed. So you have to still say, okay, I still know what's best for you. And so although I want you to be involved, but if you say, I'm not, at some level I have to intervene.
I'm interested to know how you all address the social concerns that arise. Like I know you mentioned school issues and how she missed school and other social issues?
Most kids end up, well, should end up with a 504 plan, so that they, under their diagnosis, they can have the accommodations there at the school. So if they need to run out of the room and go to the restroom at any point in the class period, they can without penalty. If they need to have if they need to carry a boost with them or drink stuff or snack during the day at certain rates, they can. If they need to be on homebound services for a while, that also will cover that. So in general, I don't know what the rates are.
We encourage our patients to always get a 504 plan when they're diagnosed, because even if they're doing great, you never know when you might not do great. It's just easier to have it on the record than to then we missed your 10 absences that you get in a year and now you're at 15 and now the truancy officers are coming trying to arrest mom. That's just never going to go over well with any parent. So we try to make sure that they have something on the books. So if you have to go to the doctors, we're not counting against you. You have to miss school, I'm just not feeling well, they can call the office and get an excuse. Now, again, don't abuse this. I'm not crazy, and I didn't just wake up, this morning and say I'm going into medicine. Like, you know your patients, and that's why you know who you're dealing with. And so, but we try to make sure they have that on file. We have our social worker usually come to our clinic and help start facilitating that. So. And the other thing would be insurance issues with our social worker, because a lot of these medications are very expensive. You cannot afford them without. So Remicade infusions, just for the medicine itself, is $5,000. That does not count what it costs to just go to the infusion center. That's probably another $5,000. So you're thinking about $10,000 every 4 weeks. People cannot afford that. So you have to have insurance, one, to cover that. And so, the S-chip has helped with that. So, if you don't qualify for Medicaid, you get S-chip, or most kids are covered. So it's not as big of a deal, but there are some patient assistance programs for these medications. But what happened with her is her Medicaid had lapsed, so that's why she did not get her medicines for 2 months, because you can't afford it. She didn't come to clinic. There were just a lot of steps in the process that kind of fell through. Mom had to work, and we're not saying not a blame game and saying, well, you should come and you should call me. Well, life still happens even when my insurance runs out. If I don't work, I don't have insurance. If I don't work, I can't make it up here because I don't have gas. So you've got to think about it in totality. Sometimes we get in our little bubble and think everybody has it and it's easy for them. It's not easy for everybody. But, that's where we rely on our social workers to help us out.
So with chronic disease like IBDs are the case here, but these patients, I feel like all of them have a tendency, like we talked about, just dealing with sort of this new disease and what that means for an adolescent. Is every patient in, I guess I use IBD clinic as an example, are they able to see a psychologist either in the hospital or in the clinic setting?
What world do you live in? Because I want to go to it. Okay, that would be perfect. In this state, no. Because there's not good reimbursement for it. We don't have a psychologist in our clinic. We've been trying to work in Raleigh to get one, and if Margot wants to come, she's welcome. But yeah, there's not. But, and not everybody has issues, but everybody probably has a little issues. Was saying, I have this, just adjusting to kind of how will this impact who I am. Right. So it would be nice to have that, just to say, to kind of stomp out issues before it gets there, because I'm not a psychologist. I'm not going to pretend to be one. But, sometimes trying to tease out those issues and what happens when I tease out that issue, and then what? If I call Children's Behavioral Health, we'll get you in 5 months. You're depressed today. What is 5 months going to do? So it definitely is a deficiency. So,
but for kids that come inpatient,
we can
do the chronic pain protocol, then they can all get access to everybody.
That links to a second question I have. Sorry. So speaking of pain and chronic pain, so I've had this patient I'm thinking about in the back of my mind while y'all are talking with chronic pain issues, not around IBD or another condition that requires a lot of inpatient stay. It's actually an issue, issues that have been more outpatient focused. And I guess I found myself now in the dilemma where she and her family have sort of been to different providers and been placed on opiates, and now she's been on opiates for quite some time. So she also lives, I think, in a family context where that's determined to be sort of a normal, okay thing. And then she has a condition that's not like IBD where you flare and you come in. It's a condition where you don't really have a reason for hospitalization of an inpatient, and so I'm sort of stuck in this way to manage her. You know, she's done doing the physical therapy because some of there's somatic complaints like maybe some joint pain and some abdominal pain. You see chronic abdominal pain a lot. But I guess my questions have to do with how to really help patients with chronic pain when you can't really get them in the hospital where you can really, have psychology and have everybody see them there. And also the challenge of picking up a patient who has already been on opiates for a while and you're worried about dependence and the parents aren't really understanding that. Sorry, I got to give you a hard question.
In many ways, that's why palliative care is seeing these kids inpatient, because chronic pain management in pediatrics is absent. It just doesn't exist. And the challenge is that, again, it's often not reimbursed because it is by definition, it needs to be interdisciplinary. And so oftentimes what happens is administration thinks, oh, well, you just need a doctor. You just need a pediatrician or an anesthesiologist or somebody who can give out medicines. And what you've seen is that, right, medicine is not the answer. So I wish that I had an answer for that. We also are so busy inpatient, we don't have an outpatient practice. And so if we hung a shingle, I think it'd be full overnight with kids that have issues like this long term. So I wish that I had a better answer for that. There are some pain clinics in the state of Alabama that will see adolescents. They don't see children, school-age children, but they will dip down a little bit and see teenagers because they tend to act a little bit more adult, and so they're comfortable. There are a couple that are probably okay, but some of these are pill mills. And so we have to be pretty careful about chronic pain clinics that are just handing out opioid scripts. If a chronic pain clinic does not have a psychologist on board, then I would be wary of that clinic. If there's not someone doing mental health in that clinic, I'd be very wary of that clinic. What do you do when you have somebody come to you and they're already on opioids? Good luck. The challenge is, right, is that there is physiologic dependence and there's psychological dependence. They've already developed both. And it's very difficult when you have a family that also doesn't see the problem in that. Those are the kids that we will then try to do adjuvant stuff and try to slowly get them off of that. We will be very honest with kids that I know you don't believe me. I know you don't see this right now. But I promise you, this is not the best medicine for you. I don't expect them to believe me. I don't expect them to be happy. I expect tears and anger and running away, and I expect that. But if I've built enough trust with them that they know that I care about them, that I really do want the best for them, that I'm not giving up on them, finally I can get to a place where I can say that. I've had pillows thrown at my head. I've had teenagers lock themselves in the bathroom and refuse to talk to me, but I come back the next day. And so I think that's the thing. Keep building the relationship. And if you start to see detrimental side effects of the opioids, then you can start to highlight those things that this is not a good thing for you long term. Does that make sense?
I think also stressing that you're still on the opioids and you're still having pain.
Yeah.
So obviously this is not working for you. I mean, let's just think through it rationally. And unfortunately, people come from painful families. So if you come from a painful family, you are more likely to have pain. So if everybody around me has pain, I'm more likely to somaticize some things. So just kind of, sometimes stating the obvious. Like, if we just keep doing this, you're already on this road. How's this going to change or get better. If you're not getting better, then we've got to do something different. And like he always says, this didn't happen overnight. It's not going to go away overnight. I'm going to continue to work with you. These medicines, a lot of them take 2 to 3 weeks for them to work. So just because, twice a day doesn't work, I may need to go up on the dose. Just saying, you need to be in constant communication, contact with me. But we just got to shift their focus.
I think if there's no more questions, we'll close out. Thank you so much for
Thank you.
being here and listening.
Thank you.